Welcome to The Kick, your expert-led podcast helping you explore and learn everything about getting pregnant, pregnancy, birth and becoming a parent.
On the podcast and our online pregnancy program, Grow My Baby, we share my experience of helping more than 4,000 babies to be born.
And our experience of running a women's health clinic and parenting 4 boys.
We're here to help everyone to feel empowered in pregnancy and birth with real-life practical information.
Welcome everyone, I'm Brigid Maloney.
And I'm obstetrician Dr. Patrick Maloney.
And we're going to do another Q&A today, Pat.
Good.
I can't believe how quickly Q&As come around. Like, we try to do one a month, and I can't believe it's been like a month since we've done one.
I love that everyone gets in touch. It's fantastic.
It is really good, isn't it? So, we like to get straight to the point and start it all off, don't we? No mucking around, no beg your pardons. Here we go. Let's go.
Hi, Dr. Pat and Brigid. I have just had my first caesarean after 2 vaginal births. My baby was breech, so it was a planned Caesar. And I just have a question about post-caesarean pain. So I experienced some episodes of pain after the Caesar that were, I would say, worse than my previous sort of mostly unmedicated vaginal birth. So really severe pain, kind of up and to the side of where the incision was, but not around the incision itself. And then I also experienced some times of just really excruciating pain where I would start off walking and be perfectly fine, and after about sort of 10, 20 meters, just be in kind of this agonizing sort of burning pain around my belly. And my question is that a normal experience of post-caesarean pain and recovery? Because I just found that the sort of presentation of the pain was really unusual and unexpected for what I thought I would be in, which would be sort of like a low-level constant pain. So, yeah, it'd just be interesting to hear about kind of what is normal post-Caesar pain and what can others expect in a recovery.
All right, Pat. So, is this post-caesarean section pain normal? What can people expect from post-caesarean pain?
Yeah, I think this is a really good question because it highlights the difference between the pain we might experience after a vaginal birth versus after a Caesar. And our caller is an expert because she's had both. So let's break this down a little bit. When we've had a vaginal birth, there's sort of 2 different types of pain to be expected. There's something called involution pain, which is where the uterus is going back to its old size and shape. And then there's also, and that pain can be severe, intermittent, sometimes brought on by breastfeeding. So every time we feed a baby, the uterus cramps a little bit, and it's the uterus trying to go back to its old size and shape, which is a big difference between term uterus with the baby and placenta still inside versus trying to go back to its old little apricot-sized non-pregnant shape. And then there's pain that she might experience around the vaginal opening from the stretching of vaginal childbirth plus or minus a tear and stitches. And that's a lot to deal with, and it tends to be a lot in the first couple of weeks. With the caesarean section situation, you get the involution pain. You don't get the vaginal opening pain because that's not where the baby came out, but you do get surgical pain because we've cut your tummy open. And so it's different. And what our listener is describing is pretty typical surgical pain, and it's not outside the realms of normality for that to still be going intermittently at 2 weeks.
And she talks about pain to the edge of where the incision sort of started or stopped.
Yeah, so this is thought to be because when we make the cut, we're certainly cutting through some cutaneous nerves in the skin, and then sometimes it's not awesome to know how the sausage is made sort of thing with surgery, but when we open the sheath, which is the strong layer under the skin that keeps our insides in, we give it a pretty big yank to make that hole big enough for the baby's head to come out. And that's you can have more bruising and swelling on one side than the other, which presumably explains why the pain can be a fair bit worse on one side than the other.
And I don't know, like it for me, I remember the very first cesarean I had, I did have a lot of right side pain at the edge of the incision, and I think it is that cutaneous nerve pain. And if I could say one thing, it does get better. Like, nerves do heal.
Yeah, absolutely. So these are the nerves that do heal. Right? So if we make a surgical cut in the skin, those nerves will settle down and heal. These aren't like, it's not like your spinal cord where the damage to those nerves can be permanent. These are cutaneous nerves that heal and grow back. So one day, she was just going to, our listeners just going to look down and go, it's really settled.
Yeah, I don't have that pain anymore.
Yeah, it'll come along in sort of leaps and bounds. But to still be needing some pain relief at 2 weeks is common. To still have intermittent pain at 2 weeks, and to still have some pain that comes on after walking 20 metres, this is normal, and what your body needs is tons of rest.
And time. Yeah. Good luck. I hope everything goes well with your healing.
Good luck.
Dreaming of treating yourself with new bed linen as we head into winter? Let us make your dreams come true. Right now, when you sign up to become a Mamamia subscriber, you'll go into the draw to win $2,000 at Bed Threads. Beautiful French flax linen, organic cotton sheets and towels to match. Yum. For as little as $7.41 a month, as a subscriber to Mamamia, you'll get access to every article, every podcast, and every single video we make. Plus access to Move, our at-home fitness app. And you're supporting independent women's media, and for that, we thank you. Subscribe today for your chance to win your dream bed combo and accessories, with thanks to Bed Threads. Click the link in the show notes and subscribe to Mamamia today for your chance to win. Entries close April 30, T's and C's apply.
All right, let's move to our next caller.
Hello, my name is Stephanie. I'm from Canada. I previously asked a question about traveling while pregnant. So I've had a baby boy December 4th, 2023. And I breastfed him for 2 years, and I stopped breastfeeding November 15th, 2025. And I have yet to get my cycle back, and I really want another baby. I've had blood tests done, and my most recent blood panel was a bit concerning. I haven't gone over the results with my doctor yet, but it looks like that my estrogen is low. It's less than 40 is what it says, and it's been low, but it hasn't been this low. This is my third blood panel that I've done since January. And my FSH is 6.9, my LH is 2.6, which I'm reading is normal. My prolactin is low, which is 3. And all my other blood results are good. My iron levels are good. My ferritin is a bit low at 70. Anyways, and my testosterone is less than 0.4. So I just don't know. Am I perimenopausal, premenopausal? I just would like some answers. So I just would love your thoughts on what's kind of going on right now. Thank you.
I love that big sigh that she gives us. It's
it
like,
was a big sigh there, wasn't it?
I'm exhausted by having to think about all of this.
That's exhaustion and frustration. Yeah. And whilst I applaud this listener's attempts to sort of nut this out for herself, what she needs is some expert guidance.
Yeah.
So
that's the thing about reading blood tests, right? Like, even when I get my blood test with the doctor that I live with, and I look at them and go, but that's like on the low side of normal. Like, what can I do about that?
Yeah. So basically, the bloods sound fine. What I don't know if she told us how old she is.
No, I don't
that's
think
a
she
shame
did,
because that would be very useful. So the things that I would be looking at in this situation, what's happening here is that it's taking a long time for the natural ovulatory cycle to kick back in after a prolonged period of breastfeeding, and it really depends. What we might do about this really depends on exactly what this couple have got planned. So what I would be asking if I'd seen this listener in my consulting room is how much of a hurry are we in here? Because in a young person, this will kick back in. And if we've got time to wait, you could just wait. The cycle will come back. There'll be a period. That's the new day one, and that should be followed by ovulation halfway through the subsequent month. And that is something we could wait for if the person was young and had enough time to wait. When we've got women in their, sort of mid to late 30s trying to have another baby, we may not have all the time in the world to wait for that. And also, it's relevant how many more babies the couple want, because we've got to sort of count backwards from our late 30s and say, right, if we want 2 more babies, then changes the time frame just a little bit. So there are treatment options here in somebody where the cycle is taking too long to kick back in, and that's something she could certainly discuss with her local doctor. The bloods, as she read out, don't indicate a premature menopause picture. They represent a postpartum amenorrhea picture, which is just that the natural cycle hasn't kicked back in yet.
Well, I'm sure she'd be pleased to hear that.
Well, absolutely. But so the most likely thing to be wrong is nothing. And then if we can afford to wait, we will, and it'll come back. And if we can't afford to wait, there are some treatment options.
Like ovulation induction or, Good luck with that. Thanks for calling from Canada.
We love that.
Yeah. And congratulations for feeding your baby for 2 years. Don't feel bad about that.
That's great work.
Yeah.
Okay.
If you're now saying, oh, well, is that the cause of me not getting my period back so I can have another baby? It's
what you're experiencing right now is nature's contraceptive, so that very reason why you don't get pregnant frequently while you're breastfeeding, it kicks on a little bit afterwards. And the cycle just hasn't come back yet.
Yeah. Good. All right.
Hi, Dr. Pat and Brigid. I love your podcast. It's been such a helpful resource during my early years of motherhood. I have a 2.5-year-old son and was fortunate to conceive him in the first month of trying. Since giving birth, my periods have become extremely heavy, needing to change a super tampon like every hour, and it hasn't improved over 2.5 years. I recently saw my GP and was found to have very low iron, which I had an infusion for. Scans showed PCOS, 24 follicles on one and 20 on the other, and possible endo as my ovaries aren't mobile. My AMH is 50, my hormones are all normal, and I'm booked to see a specialist in June. My husband and I have been trying to conceive for 6 months. I have a healthy, active lifestyle, eat an anti-inflammatory diet, and have regular cycles between 30-34 days. I usually ovulate around day 18 with a luteal phase of 14 to 16 days. I don't have typical PCOS or endo symptoms, just very mild back pain. My question is, if everything seems fairly normal, why am I struggling to conceive? And how might PCOS and possible endo have developed since my first pregnancy, despite a healthy lifestyle? I feel like I'm doing everything I can, so what should I consider next?
What a great question.
Question.
I'm sorry. I'm excited by the question. I'm not excited for you. That sounds
I'm sorry to
awful.
hear you're having trouble, but how well informed is everybody saying today? It's fantastic. So this is somebody taking a very active and well-informed and educated approach to her own healthcare, which is music to our ears, isn't it? I think that I'm also hearing a little bit of frustration here, because here's someone who's taking their health seriously, being very active and healthy, and yet is running into an issue. And of course, that's common, and it doesn't always work that way, that the more attention we pay to our own health, that we can necessarily, it's not a get out of jail free card.
She also doesn't tell us what her period was like before she got pregnant in the first place. Or if perhaps she was on the pill or some other suppression. And this might have been her pattern even before pregnancy.
100%. So that's the problem, isn't it? Is that often, for perfectly legitimate and sensible reasons, people have managed their period in one way or another to try and avoid pregnancy in their early years, or manage a painful cycle or whatever. And then they might come off that contraception that they've been on since teenagers in their mid to late 20s to try for a pregnancy. Their body's in pretty good nick at that stage. Bingo, they get pregnant, fantastic, breastfeed that baby for a while, wait, try again. Now we're a little bit older, and suddenly we start to have a few problems. And it's tempting to think that those problems are brand new, and why has this happened now? And a lot of the time, they're problems that have been there all along, but have been pretty well managed by the pill in the early stages. We were fortunate enough to get pregnant without intervention the first time around, and then, of course, masked by pregnancy and breastfeeding, because in those years, not menstruating anyway, no reason to think there's a problem. So when our caller came and had her ultrasound, the ovaries had a polycystic appearance. And, of course, they may always have had a polycystic appearance. She doesn't sound like she's got full-blown textbook polycystic ovarian syndrome with the weight issues and the acne and the excess body hair. But they may always have had this polycystic appearance, and it's just that when she first tried for a pregnancy, the ovary was easily capable of monthly ovulation, and now maybe less so.
Sounds like she's still having a regular period that she can bank on.
Yeah, which is good, but the cycle's a bit long, isn't it? Oh. And when she tells us that she's regularly ovulating, I wonder what evidence we've really got for that. So an ovulation predictor kit, which a lot of people use, that's the pea on a stick one from a pharmacy that says you're going to ovulate tomorrow. It doesn't measure ovulation. It measures a hormone that comes out of your brain that tells the ovary to ovulate. And the presence of that hormone doesn't actually mean that ovulation was achieved. It's a good start. So what we'd be looking for is some post-ovulation testing of progesterone levels just to confirm that it really did happen. The evidence that we've got that it did happen is that the luteal phase is about 2 weeks long. That's a good start. But I'd be looking for a blood test as well. And the endometriosis situation is a bit less clear. Ultrasounds, and I always say that, but not all ultrasounds are created equal. There are very, very high quality ultrasounds that people can go and get. In Australia, they're called COGA scans, done by experts, super experts in pelvic sonography, and they're pretty good at picking up in endometriosis. They don't pick up every case, but they're certainly very good at ruling in or out the severe cases. Whereas an ultrasound done at a corner ultrasound provider, where 1 minute they're scanning a woman's ovaries and the next minute they're doing a brain CT and the next minute a broken arm, and those ultrasounds done at general imaging clinics are perhaps less reliable. One of the things that they're looking at on those ultrasounds is mobility of the ovaries. And that, in my experience, is highly operator dependent. So I don't put much store by that finding unless it's by a highly experienced ultrasound provider. So when we do a transvaginal ultrasound and push against the ovaries, it's a subtle sign that they're fixed in position. And sometimes when I read that on a report, I take that with a grain of salt. And I'd be looking, is there any other ultrasound evidence of endometriosis in this woman's case? And then I take a very careful history and try and elicit any other signs or symptoms of endometriosis so that we could build a case whether endo was likely or not. Because if it seems likely that there's endometriosis, of course, that could have developed since the last pregnancy, or more likely it was present all along. But when the woman tried to get pregnant the first time around, she was several years younger, the endo was less severe and it wasn't enough to prevent conception. A few years later, it could be. So we have to look at all of these things on a sliding scale of severity, and also factoring in that by definition everyone is a few years older than they were a few years ago.
And can I ask about the super heavy periods, because they sound awful?
Yes.
Having to change a super tampon every hour during her period.
So they are too heavy. The issue there, though, is what we're trying to achieve. So, for example, in someone who had finished their family or was not trying to achieve a pregnancy, we've got treatment A, B and C. But a lot of the good, pretty much all of the good treatments for a heavy period are also contraceptive. We use the pill, we use marinas, we use operations, but these are all contraceptive things. And obviously not a suitable intervention for someone trying for a pregnancy. So the best treatment for this woman's heavy period given that she wants to be pregnant, would be to get pregnant as soon as possible.
So her next steps?
Needs some expert advice, needs a thorough assessment. This is not a benign situation. If we do nothing, we might miss out. So I can't say firmly enough that this needs to be investigated, and I would be looking at whether we can get a serious expert ultrasound done, some more hormonal testing, and a reproductive opinion about what's wrong, and if we can get that fixed. By intervening early, we can help a lot, and we can make sure that people not only get a pregnancy but get a desired family size.
Can I ask a logistics question?
Yeah.
So is she better to get her GP to send her to that super duper ultrasound, a COGS ultrasound, or is she better to go to her gynecologist first and then that gynecologist refer to the COGS?
I've got no problem with people being sent for a tertiary level or sophisticated ultrasound scan just from their GP. I think that's a good idea, and I think that a lot of women's health GPs who understand the difference between an ordinary ultrasound and a high quality one are comfortable making that referral first.
And what can she, if the GP doesn't know, what is she exactly asking her GP to do?
Is to get a high-quality ultrasound done by a dedicated women's imaging service.
Great. All right. I hope that's helpful and good luck. I hope you're got some solutions soon to get you towards your pregnancy.
Good luck.
Want to feel good more often in 2026? Hi, we're here for you. Move by Mamma Mia helps you fit movement into your everyday, giving you more of me time whenever you need it. From strength and cardio to yoga and Pilates, with workout plans that fit every space, every body, and whether you've got 10 minutes or 40. Start 2026 with enjoyable movement from just $9.99 a month. Mamma Mia subscribers get unlimited access. Head to move.mamamia.com.au and use MoveMe to get $20 off an annual subscription.
All right, let's go on to this one, Patty.
Hi Bridget and Dr. Pat. My name is Sarah. I'm 39 years old, 29 weeks pregnant with my first, who's an IVF baby, and calling from across the ditch in New Zealand. I have placenta previa, and I've found the information you've provided to be absolutely invaluable for understanding what's going on and what it means, and so helpful in stopping me from freaking out about it. So thank you for your podcasts. I have two questions for you. The first one is a bit more serious. At the 28-week scan, they spotted a 14-centimetre umbilical vein varix. Because all the 20-week anatomy was normal and he's a 75th centile, it seems likely it's an isolated finding. I've been given a non-urgent, good sign, referral to fetal medicine specialists, and I'm expecting an increased, probably weekly scan schedule later in my pregnancy. It's not something my midwife has seen before, so she's not been able to tell me much about it. So I was hoping that you could explain a little bit more about it, please. My second question is a bit lighter. You've talked a lot about trying for a second while breastfeeding and how breastfeeding can affect ovulation, but what would it mean for a second IVF baby using frozen eggs? Thank you so much.
All right, Patty, I missed what she said that was the diagnosis for the umbilical cord. Varicose, was it?
So they think they can see an umbilical vein varix, which is like a varicose vein.
Yeah.
Yeah. There are a number. Ultrasound's getting really good.
Yeah.
So they get incredibly good at it. And, it's funny to think that proper ultrasounds that were actually of any use really only came in round about when I was a baby. So, we've really only had decent ultrasound for about 50 years, and it's gone from something where the pictures were ridiculously bad and all you could find a placenta previa with it and that was about it, to these unbelievably clear images with a sophisticated ultrasound machine where they can find so much stuff. And what they find these days is a lot of really important stuff, but also some very minor changes in placental and cord anatomy that probably don't mean tons for the progress of that pregnancy. And they'll often say on the report, we found this slightly funny looking cord, and in some studies this is weakly associated with third trimester growth restriction or other issues. And so we sometimes that person will get referred to a maternal fetal medicine specialist or whatever, and they say, yeah, there's some evidence that weakly associated. And with a lot of these relatively subtle variations in cord anatomy, they would recommend more frequent scans in the third trimester to look for fetal growth and well-being.
Yeah, and she's saying that the baby's in the 75th percentile.
Yeah, so baby's growing fine.
Yeah.
And occasionally they might detect a third trimester growth issue, and whether that's from the subtly abnormal cord or whether it's from
other
anything
things,
else, of course we never know. But this is the sophistication which we've come to over these things. And when you have information like that, it's hard to unknow it.
Yeah.
Yeah, so often we'll say, fine, let's go and do those scans. But so often it doesn't come to anything significant. If there is an issue, it's dealt with, with appropriate expertise.
Yeah.
The other question's an interesting one. She doesn't need her natural cycle to return. And so what people often do is breastfeed for as long as they want, and then contact their IVF provider and say, rightio, I'm ready to have a frozen embryo transfer, but I'm still breastfeeding. What do you recommend? And they would say, fine, breastfeed up until this date, and then do X, Y, and Z to have the uterine lining ready for another transfer. So
it is still impacting on the uterine lining, whether she's breastfeeding or not, potentially.
Yeah, that's why you don't. One of the reasons why you don't menstruate while you're full-time breastfeeding, lining's pretty thin, and that wouldn't suit a transfer. So they'll say, fine, breastfeed up until this date, and then do this, this, and this, and then we'll see you for a transfer when the lining's nice and receptive on ultrasound. Let's say she is breastfeeding, but her periods have returned. Then she could just keep breastfeeding and have the embryo transfer? They would use ultrasound to make sure it was the right thickness. Yeah, we don't want to waste them or transfer them when the chance of success is low. Yeah, because a high quality frozen embryo has an excellent chance of turning into a baby. Yeah, and they want to keep those. So the question is not how is it done. That's all easy. The question is how much time have we really got. It's nice to have frozen embryos because they're locked in time and frozen in time, and you could have those transferred at any point. But lots of people still want to have finished their family by their early 40s, even someone who started at the end of late 30s and had IVF. So for social reasons, we often want to get on with it. So sometimes there's a bit of a give and take between the desired breastfeeding time versus the realities of transferring the next embryo and getting on with the next pregnancy. Yeah. Good. All right. Well, good luck. And speaking of time, I think we've only got time for one more, Pat. Okay.
Hi, Dr. Pat and Brigid. I'm 10 weeks pregnant with my first baby. I have been doing IVF for 2.5 years now. So in preparation for that, have been preparing for potentially having low iron. I do already have low iron, so I have been taking a supplement every single day to get my levels up. Unfortunately, prior to falling pregnant this time round, my levels were quite low. I think they were about 20, which is borderline not great. And then since falling pregnant, my levels have dropped even further, that I now have levels that are way too low. Unfortunately for me, I'm that very small percentage that is anaphylactic to iron infusions. So in saying that, I just sort of wanted to know what my options were moving forward. I'm still trying to take my tablet every single day, but it doesn't look like my iron levels are moving. Thanks.
Yeah, tricky.
Firstly, I hope that she didn't find out that she was anaphylactic during an iron infusion.
Well, presumably she did. I don't know that there would be any other real way of knowing that. So I'm sorry that happened to you. Congratulations on the pregnancy.
Yeah, 2.5 years. Yay.
I think this is great news that you're pregnant and you're doing a good job. Iron's important in our body to run all sorts of metabolic processes, and it's important in pregnancy. You need iron to run your body, and then you've got a baby growing inside you that is stealing some of your iron for their own metabolic needs. So that's where this problem of people who run low iron but cope okay suddenly can wind up in trouble in pregnancy. On the upside in pregnancy, you're not menstruating, so you're not losing iron that way, but but the pregnancy itself takes a fair bit. So you're doing a good job. It's unfortunate that we can't give iron infusions because that's our get out of jail free card. We can use infusions to bypass the gut. And in people who don't absorb iron pretty well, that's usually the problem, that the bit of the small bowel just beyond the stomach where iron is absorbed is just not very efficient at doing that. So what else can we do to help? Firstly, you're doing a bit better than you think, because if you are taking an iron tablet every day and that's not constipating you too badly, but the levels are staying about the same, just the lowest end of the normal range, given that the baby is continuing to take it, if you were getting absolutely nowhere, those levels would be going backwards. So if you feel like you're maintaining a poor level, but it's not getting distinctly worse, then you are winning a bit more than you think you are. How can we make them go up even further? You could look at the type of iron supplement that you're on. There are a number of different ones. A good dietitian can really help you with that. Some forms of iron are much more easily absorbed than others. The addition of vitamin C can help absorption of iron in most people. But the other reason why you might get a consultation with a good dietitian with experience in the pregnancy space is that you could be looking at everything else in your diet and maximising iron that way. Give or take, our body's a bit better at getting iron out of the traditional sources of meat and some plant products better than a pill. And so you could be doing both. So dietitian, maximise natural sources, make sure we're on the right iron, don't have an infusion if you're anaphylactic, and be confident that if you are maintaining an iron level that's low but steady, that you are actually absorbing some.
All right, good luck with that. There's lots of dietitians around. We've had Steph Valakis on our podcast a couple of times, and she's really dedicated to the perinatal space, so you might want to look her up if you can't find someone locally. All right, everyone, that's us for this week. If you're wondering, how do I get my question answered on the SpeakPipe, go to our website and there'll be a link to the SpeakPipe, or even click into the show notes. There's also a link there. We do give priority to people that are in our Grow My Baby program. So if you are thinking that you are urgently wanting something answered, that's not a bad way to jump the queue. So until next Q&A, keep listening. We'll be back in your ears next week, and I hope you're having fun growing your babies.
Thanks for listening, everybody.
Bye for now. Hey, even though Dr. Pat is, well, a doctor, and we get lots of other doctors and other experts on our podcast, I just need to remind you that this podcast is for informational purposes only. We share lots of medical insights and experience, but everything we talk about is general in nature and may not apply to your specific situation. Please always consult with your own healthcare provider for your individual medical advice when you grow your baby.
It's Monday morning and your mind is already racing.
And you're replaying an awkward conversation you had during the week. Your inbox is full, your patience is gone, and life just feels like a lot.
I'm Ashani Dante, and alongside with clinical psychologist Dr. Anastasia Herodes, we're here to help you unpack the messy, honest stuff that keeps you up at night.
And this is But Are You Happy? The Mamma Mia podcast where we skip the fluff and dive into the real talk you actually need.
This is the mental health podcast you and all your friends need. Listen to But Are You Happy now, wherever you get your podcasts.